Diagnostic Approach. The initial diagnostic test of choice in an adult with a persistent neck mass is contrast-enhanced CT, 20, which provides valuable initial information regarding the size, extent, location, and content or consistency of the mass. Additionally, contrast media may help identify malignant lymph nodes that are not enlarged and distinguish vessels from lymph nodes. 20. Table 3 shows the preferred imaging modalities for neck masses and lymphadenopathy according to American College of Radiology appropriateness criteria. 20 Of note, contrast can obscure visualization of sialoliths, and non-contrast enhanced CT is recommended for suspected swollen salivary glands due to sialolith obstruction. 20 Iodine-based contrast media should be avoided in patients with a history of thyroid disease or when metastatic thyroid cancer is a concern. 20 Although positron emission tomography, PET, with CT can be used to distinguish between malignant and unaffected tissues, its use in the preliminary diagnosis is not as effective and should be limited to definitive management of a malignancy. 20. Enlarged print. Table 3. Preferred imaging modalities for neck masses or adenopathy in adults. Scenario recommended test comments. Non-pulsatile solitary mass or multiple neck masses. Contrast-enhanced CT. Pulsatile neck mass. Contrast-enhanced CT and contrast-enhanced CT angiography may be performed at the same time. Patient with a neck mass and history of cancer treatment. Contrast-enhanced CT or CT with positron emission tomography. Positron emission tomography is superior in this subset of patients. CT equals computed tomography. Information from reference 20. When ultrasonography is indicated instead of or in addition to CT, it is useful to distinguish cystic from solid lesions, detect nodal size, and differentiate high-flow from low-flow vascular malformations. 20 Ultrasonography may also be helpful in guiding FNAB of non-palpable or small superficial lesions. 20 Although CT and ultrasonography share similar capabilities, ultrasonography is often preferred initially in younger patient populations to reduce radiation exposure. It may also be preferred to avoid contrast media-induced nephropathy in patients with underlying renal disease. CT angiography is recommended for evaluating a pulsatile neck mass and is preferred over magnetic resonance angiography, MRA. 20 CT, MRA, and PET with CT are all useful in the evaluation of patients after cancer treatment. PET with CT appears to be superior to MRA or CT for detecting recurrent tumors, but it should be considered only on request from the surgical oncology team. 20. The clinician may proceed with FNAB, if indicated, once appropriate imaging has ruled out involvement of underlying vital structures. FNAB can provide further information through cytology, gram stain, and bacterial and acid-fast bacilli cultures while avoiding complications of open biopsy. The sensitivity of FNAB for detecting a malignancy ranges from 77% to 97%, and the specificity ranges from 93% to 100%. 7, 13, 14, 21 FNAB should never be performed on a pulsatile mass or a mass that appears to be vascular in origin. Patients with suspected infectious and inflammatory masses should be tested for HIV, Epstein-Barr virus, cytomegalovirus, toxoplasmosis, tuberculosis, and B. Henseli, when clinically appropriate. Endocrine masses can be assessed further with blood work, including thyroid and parathyroid hormone panels. Visualization with laryngoscopy, bronchoscopy, or esophagoscopy may have an important role in further evaluation of neck masses that are not adequately characterized by ultrasonography, contrast-enhanced CT, or FNAB.